Welcome everyone and good afternoon. I'm Nachal Anastri from Johns Hopkins and I'll be moderating our journal club session. Today we're fortunate to have Dr. Adam Sharp presenting his manuscript, Missed Acute Myocardial Infarction in the Emergency Department, Standardizing Measurement of Misdiagnosis-Related Harms Using the SPADE Method. So I'd like to introduce today's journal club speaker, Dr. Adam Sharp. He is a board-certified emergency medicine physician at the Los Angeles Medical Center. Dr. Sharp is also a research scientist at Kaiser Permanente, Southern California's Research and Evaluation Department, and a faculty member at the new KP Bernard Tyson School of Medicine. His work is focused on improving the effectiveness and affordability of healthcare by embedding research methods into quality improvement projects. Dr. Sharp's research has identified gaps in healthcare quality and has reported the impact of quality improvement interventions that were designed to narrow those gaps. His work has improved antibiotic stewardship, the appropriate use of diagnostic CT imaging, and the emergent care of stroke and chest pain. Presently, he's working to identify and address the social determinants of health within the healthcare delivery system. Welcome, Dr. Sharp. Thank you for presenting today. We'll turn over the slides to you.
Great. Thank you, Najla and Vanessa, and thank you for those of you that have joined. It's my honor and privilege to present to you today. I know that we find ourselves in really interesting times, especially being here in Los Angeles. We are still inundated with the pandemic, but I'm grateful to be able to present this work to all of you. Let's see. All right. Is this showing up all right for everyone?
Yes.
All right. So as was already presented, this I'll be primarily going through and outlining a recent publication in the very CITM's own journal Diagnosis that was published just a few months ago, was accepted last summer and published shortly thereafter. I want to start by acknowledging the variety of individuals that contributed to this, some of whom were able to join today. So I hope that they will feel welcome and free to add anything that they would like to as I go through this brief presentation. And I'm grateful for the format that actually allows for the bulk of the time to be spent on discussion. But as you can see here, this is primarily a team made up of our research and kind of embedded research team here in Southern California, as well as the Johns Hopkins team back east. This was a result of a project funded by the Gordon and Betty Moore Foundation, but no other conflicts of interest to report related to this work. Let me make sure my timer's on so I don't go over here. So much of this background is information that those of you that would attend this type of a conference already know. There are a lot, millions and millions of diagnostic errors estimated annually. A large proportion, or a third of these, have been found to result in serious patient harm. Those of you that are not emergency physicians or hospital-based, clinical providers may not know that chest pain and symptoms, which is the most common symptom suspicious for acute coronary syndrome, is the second most common reason that patients visit the emergency department, followed only by abdominal pain, which more things to hurt, I think, generally in the abdomen. One of the issues in terms of the background related to heart attacks, which is the condition that we worry about with suspected ACS or acute coronary syndrome, is you'll find a lot of different miss rates that we can, in our paper in the background, you'll hear anything from 2% to 34%. Now 34 is really high, but that's part of the problem and the need for a standardized approach. And so the SPADE methods, which you may have known or heard about, that David and others have put together related to stroke, may offer an approach for other conditions. And in this case, that was kind of the impetus of the project, is to see if this same approach would be useful for identifying patients with potential missed AMI. So you'll see here, this is kind of the conceptual model that has been created. over many years of work that we used. And I'll highlight a couple things here. I think there's strengths and weaknesses to a variety of approaches, and one of the things that the symptom disease pair analysis of diagnostic error, much easier said as SPADE, does is, if we identify the potential condition that might be missed, so in this case, if we use stroke or heart attack here on the right as the dangerous diagnosis confirmed, and then look back some amount of time, and generally that's 30 days, but could be any amount of time to see, what symptoms may be led to that is probably the most sensitive way to do it, and gets us the largest number of potential misses or opportunities to make the right diagnosis. As an embedded or implementation researcher, that kind of works within the health system, this is hindsight, right? So hard to do much about this. Obviously, physicians aren't intentionally missing these types of serious diagnoses. And so that leads us to the look forward analysis here, where you start with the symptoms that were identified and associated with that dangerous diagnosis in the look back cohort. And then you look forward to see what happens to that group, which obviously presents different patient populations and a much different denominator. But what I like about this in particular is it offers an opportunity for improvement. So it gives you a group of patients that might be targeted for actual clinical changes to avoid misses. So in terms of our methods, for those that might not be familiar, Kaiser Permanente has multiple regions across the country, 8 to be exact, and we're the Californias are the kind of the behemoths of the group. So we're in Southern California. We're an integrated health system. We have 4.6 million members. In our data set, we're fortunate because we have detailed information about patients who come to our clinics or our hospitals. Everything from vital signs to the lab results and everything that goes with the EHR. But we also are fortunate to have claims data for those that go out of network to other hospitals or emergency departments. It says 12 to 15 EDs here because we've grown and a couple of EDs have been added, and over the timeline of the 9 years that we looked at data for our patient population. So as mentioned, this is a retrospective study looking back over time using that general population of patients in our clinical setting using the SPADE, both look back and look forward approach. The primary outcomes were a primary diagnosis of acute myocardial infarction. This approach in previous research has been shown and validated that it's an accurate way of identifying patients with an actual heart attack. And then similarly looking at ED visits within 30 days prior to the AMI in the look back. And then we'll talk a little bit more about the look forward as mentioned before. So I know there's a lot of data here. You'll see, I guess I want to draw your attention to a couple of things as we think about this that sometimes is a challenge as we present this together. But if you look at the look back analysis, so over the 9 years, we had almost 44,000 plus patients with a primary AMI diagnosis for hospitalization. And you'll see a much higher over to the right, patient population with over 325,000 patients when we use a look forward, just using the symptoms that we were able to identify in the look back analysis. You'll also see, as a result of a very different denominator here just on top, that though the number of AMIs included is similar in the 500 range, the 0.2% and the 1.3% are obviously a result of the very different denominators used for the patient populations. A couple other small things to note, not surprisingly, you'll see those that actually had an AMI, which is what we started with in the look back analysis, are much older, almost 20 years older than the patients looking forward, and have a lot more chronic conditions compared to the look forward analysis, which you might expect as we found and expected that these patients are sicker and have a lot more comorbidities, and the risk factors that we have known for some time contribute to AMIs. So starting with the look back, as I mentioned here, part of this approach allows us to find any ED visit in the preceding 30 days, which as the highest possible number of potential misses is in our cohort 6.7%. As part of the SPADE methods, as I mentioned before, is clinical plausibility and actual known kind of physiologic or biologic causes for AMI are important. And just to give a simple example, as an emergency physician, if I have a patient who comes in with painful urination and I'm evaluating them for a urinary tract infection, it really isn't feasible or appropriate or clinically recommended that patient be worked up for a heart attack, even if they may have one within 30 days. Thus the moving to what we used here were the top 20 CCS diagnoses. If you're not familiar, the CCS is the clinical classification software as part of the HCEP databases that the Agency for Healthcare Research and Quality, or AHRQ, uses to cluster similar diagnoses. And so we clustered in the most prevalent CCS diagnoses with the highest observed to expected ratio. And as we did that and looked again back at clinical plausibility and the things that would be of most likely to a symptom suspicious for acute coronary syndrome or a heart attack, non-specific chest pain and dyspnea were the two symptoms that met that criteria. And with those symptoms, as are defined, quote, miss in the 30-day events prior to an AMI diagnosis, that gets us to the 1.4% missed in our look back cohort. As you can see here, using observed to expected ratios, we show a much higher observed to expected ratio in the chest pain dyspnea group compared to, we chose just to use these as an objective kind of control group. So patients with sprains and strains or superficial injuries or contusion, you'll see are actually less likely have a lower, observed to expected ratio than the general population of having an event. I will mention, I guess, just briefly here that the way that we calculated the observed to expected ratios is, so in the numerator, the observed was just the observed diagnosis encounters divided by the total number of 30-day ED visits in the patient population, and our expected, we took 2017, which is the last year of our timeline, and we took all diagnostic encounters for 2017 divided by the total number of ED encounters to give kind of a general expected, based on a year of ED visits, what the expected ratio of patients for those reasons might have an AMI within 30 days. You'll see here, this just kind of shows graphically that by day, so starting on the right, -1 is 1 day prior to the AMI hospitalization, and you'll see that much higher risk within the first 5 to 7 days here. In the blue or light blue, you'll see that the dark blue is for those with chest pain, and the lighter blue is those with a dyspnea diagnosis. And then again with our controls, sprains and strains, which are relatively flat, but you'll see the bulk of these, as we define them, misses come in the first week to 10 days. I'll also mention this is consistent and similar to what was found using the same SPADE methods for when they linked dizziness to potential missed stroke encounters, had a similar pattern to this. So with our look forward, as mentioned before, we have a much larger patient population. So we have the over 325,000 chest pain or dyspnea ED encounters, and looking forward 30 days from those visits for those causes resulted in a similar number of AMIs, but a much lower percent of quote misses. I'll point out here, I think this is, again, part of the reason that you'll see wide variations in reported misses based on different ways to measure them, which we found in this cohort here. And as you see here, the expected miss rate for all ED visits was at 0.07%. So had a similarly high observed to expected ratio for the look forward results for patients with chest pain or dyspnea compared to the general expected rate of 30-day AMIs after any ED visit. Well, let's go to the next slide. Similarly to the look back, you'll see here, starting with 1 day after the visit, we see the highest number of misses in the first week to 10 days or so. A little bump here at 12 days, but in the number of patients that came back with a heart attack with one of these conditions using the CCS codes, as I mentioned, and also similar to the other cohort, you'll see kind of a flat control group here of those that had superficial injuries or contusions or sprains or strains as part of their ED visit. You'll see here, this is our more detailed observed to expected kind of statistical comparison for patients that come in. And you'll see in the look back, which has the most detailed information here, that the non-specific chest pain, if you look at the expected proportion versus the observed proportion, you see about a 10% difference in the number of patients that this is an absolute number here, and then you'll see the observed to expected again in the 2.5 range to the right. Just for comparison, you'll note here that among the patients like with abdominal pain, which again is, as I mentioned before, for overall ED visits is the most common complaint that we see in emergency departments. The observed to expected is much smaller, even though there's a relatively large observed count compared to dyspnea. COPD, I'll just again here, COPD, we know many of the common risk factors for cardiovascular disease are similar in COPD, and you'll see a slightly bumped observed to expected ratio in this category, which one might argue that we could include it as a potential miss. One of the things from a clinical perspective is obviously we typically are thinking about a type 1 acute myocardial infarction when we talk about misses, which would mean a primary obstruction of the coronary arteries, as opposed to a type 2 AMI, which might be from demand ischemia from things like COPD or sepsis or other causes that have different clinical relevance, obviously, and more challenging in terms of defining misses. And as mentioned before, you'll see down below a much smaller risk and difference in risk for the look forward cohort of patients here. I will mention, one thing about this as we put this together. We included patients only administrative data in order to do this. Now, there's obviously strengths and limitations to that approach, but one of the reasons that we decided to do that, as I get to the conclusion here, is we felt that it was more generalizable. Obviously, not all were unique as an integrated health system. And so many systems don't have the detailed information that we had, so that we intentionally included even patients that were seen outside of our system and just used administrative data. So I feel that though we're a unique system, that our approach could be used for any health system or health plan that might have administrative data available to them. So as you can see here, we concluded that this was a method that was feasible for AMI in the same way that it was for stroke and dizziness. As I mentioned, that we quantified about 1.3% in our look back, which though maybe a small percent, represents an overall large number of patients that might be seen annually in the United States. The look forward was a much smaller percentage of visits missed. And we found that, focusing potentially on the 5 to 7 days after a visit is, there's always a question around the timeline that's most appropriate, but that's where we saw the largest difference in potential misses. And as mentioned, this, from an implementation, from a, how do we improve and actually get to where we want to be, which is, identifying those at high risk and decreasing the time between
35.
when we're able to actually identify these serious conditions like AMI. And it's challenging with the 0.2%. So identifying a potential high risk patient cohort with these chest pain dyspnea symptoms is a possible next step, among others. So with that, I think I am at our 15 to 20 minute mark here. I look forward to your input and questions and comments about our work and this approach.
34.
Great. Thank you. Thank you, Dr. Sharp, for the wonderful presentation. We'll open up the floor for any questions or comments. You can feel free to unmute yourself to ask the question, or you can type in a comment in the chat box. We'd like to ask for you to mute yourself unless you are speaking. Thank you. I think, John, did you have a question? You can feel free to unmute yourself.
Yes, thank you for that presentation. It's very interesting work. I'm a little confused about how you calculated the observed and expected, and I think it might help to run through an example, which I will give you, and you can give me the observed and expected. But if I am giving you silly numbers, just let me know. But let's say 100 patients present to the emergency room in a given month, like November of, it doesn't matter, but November of 2020. That's not a month you studied, I don't think. So 100 patients come into the emergency room, total of 100 that month with all complaints. And 20 of them have nonspecific chest pain. And let's say 5 of those have an MI. I don't know whether it's missed or not missed. Let's say it's a total of 5 that had an MI. And maybe 1 of those 5 had a missed MI. So now we've got the numbers. 100 total visits, 20 had chest pain, 5 of those with chest pain had an MI, and 1 of the MIs was missed. So what's the observed and what's the expected? You're muted.
So,
there you go.
Yeah, really great question. And thank you for the concrete example, because that always makes it a little bit better. So can you guys still see I tried to copy and paste this. Can you still see my screen?
Yes.
Yes.
So this is the way, this is how we calculated the observed to expected ratio. So for our observed, we took the total number of 30-day ED visits. So as you remember, in our look back cohort, we had like a 6.7% amongst all ED visits, and looked at the observed diagnosis encounters for the ones that we came up. So in this case, chest pain and dyspnea. So in our look back, that was our observed. We had, amongst all of our ED visits, what proportion of those in the 30 days prior had the chest pain or dyspnea diagnosis. That was our numerator. In our denominator, what we did is we took a much larger 1-year grouping of all of our total ED encounters divided by those that were for chest pain or dyspnea. And so that was the way, that it was just a simple numerator denominator with these definitions is how we came to the observed to expected ratios. It looks like
So now if we use my example,
yeah.
Let's go to the denominator first. So the total number of ED encounters was 100, and the diagnosis encounters, is that the number of MIs or the number of chest pains?
So in that example, actually, John, your number would be 20 observed chest pains. You have a total of 100 ER visits, but only 20 of those are chest pains. So in that case, the observed would be 20.
Okay. So when you have observed diagnosis, that's not really observed diagnosis, that's observed symptom of chest pain. And the total number of 30-day ED visits was 100. So 20 out of 100. So the observed in that case would be 0.2.
Yeah.
And now what's the denominator?
And the denominator, so I mean, this is the part. So, so let me give you. So let me give you. So the denominator would be the number of, instead of just the small group that you mentioned of 100, it would be compared to. And I will say that this observed diagnosis is in the look back cohort. So we're talking about observed is a group. If you took all of your heart attack patients. And so we're going to say that of the 100 heart attack patients that had a heart attack, we look back 30 days and 20 of them had a chest pain diagnosis. So we get that for 0.2. So as you mentioned, and down below for the denominator, which would be the expected, we would take over the course of a year, all ED diagnoses, all ED encounters, as opposed to those with an AMI, which would be our total down below, and divide that into the number of chest pain encounters. So,
Okay, so in my example, so the numerator is 1 month and the denominator is 1 year. Is that right?
in this case, I mean, yeah.
Okay, yes. Sorry to interrupt. I was part of the research team, so that's why I can fill in a little bit. Yeah, so the denominator is the ratio of, or the proportion of chest pain patients that were seen in the emergency room in 2017.
Okay,
So,
so in my example, I had 100 in a month. So let's say in a year, that's 1,200 total ED visits, and chest pain would be 12 times 20, which would be 240. So there were 240 chest pains among 1,200 ED visits for the year. So now the observed to expected ratio is identical.
Mm-hmm.
Because 20 over 100 is the same as 240 over 1,200, I hope.
Yeah, so in the case that you mentioned, if those were our findings, then we would not have thought that I mean, this, again, as part of the SPADE methods, if we found that the observed to expected was near 1, we would not link that to a missed opportunity.
So there's nowhere in this math do I see missed opportunities. All I see is observed diagnosis, which is really not diagnosis, but observed symptom of chest pain. And it's the only thing that's different between the numerator and the denominator is the time period. So the same ratio would apply whether you're talking about 1 month or 1 year. And there's nothing in there about misdiagnoses, or actually there's nothing in there about MI. There's no, in that previous slide that you had, I don't see where MIs are, and I don't see where missed MIs are.
Yeah, so sorry about the confusion, and if others maybe are able to explain this a little bit better, I'd welcome those that were part of our group. So if you can see the screen here, this is just the basic conceptual model for this SPADE methodology. So, you know, part of the difficulty in understanding this is because we use 2 different patient populations, and so we calculate the O/E ratio slightly differently in the 2 patient populations because we intentionally used 2 approaches here. So we start with a patient population where everybody has an AMI. All hospitalized with an AMI diagnosis is who we started with in our look back diagnosis. So everybody had an AMI. So we don't have to necessarily, we don't have it included in the O/E ratio because everybody had one. And the observed is looking back from amongst the patient population of AMIs, and amongst those who had an ED visit prior to that AMI visit, what was the proportion that had chest pain or dyspnea. And that's kind of the first step in this methodology, is to try and link amongst those CCS codes, as I mentioned, um, a symptom that might have a much higher likelihood of being a true miss. Now, I think you highlight that the limitation in this approach is that we did not do the deep dive that certainly could be done to look at each individual encounter to identify it was truly, quote, a miss or not. And so this is a kind of a large health system population or a hospital view from that perspective, and it comes with strengths and limitations. But does that make a little bit more sense using the look back cohort of why? And so comparing, as we mentioned, to all the other potential, like I said, we looked at 20 of the top diagnoses for all ED visits preceding an AMI hospitalization. And as part of that process, that's where we got to chest pain and dyspnea, which using this methodology is how we defined, again, it's not perfect. Some of them may not have been true misses, but it gives us a standard approach and a standard amount that we can use to potentially improve.
Well, I see why I'm confused about the AMI, because as you say, everybody had an AMI. So it's sort of the study population. Everybody had an AMI. How about with a look forward, though? In that case, it's not everybody with an AMI. It's not even everybody with chest pain. It's everybody who visits the ER. Is that right?
No. Yeah, no. So you start with the look back, and once you've identified the symptoms you think, based on, as I mentioned, that you think are linked to potential misses, then when you do the look forward, so these initial symptoms here on this left side, this is just chest pain and dyspnea diagnoses. So this is just those symptoms and the diagnostic codes associated with them that you think are linked to misses, and then you look forward 30 days to see who had a heart attack. And so this is a different patient population, very different. But that's how you get your observed number in the observed for the look forward. And in the expected, again, you'd use the same calculation, but again, a different population to get the expected numbers, which would be all ED visits divided into the number of those that had those diagnostic codes that we thought were linked to misses.
So I'm still not sure whether when the look forward is the study population all patients with chest pain and dyspnea, or is it all patients, period?
Yeah, the study population and the look forward were all patients with chest pain or a dyspnea diagnosis.
Okay. And so that's the denominator for both observed and expected?
No, that's the observed, because that's just the observed in the population, and then the expected, as was mentioned. So I think maybe the expected in the look forward is where we use the 2017 ED visits divided into all chest pain and dyspnea visits, if that makes sense.
Hi, Adam, we have more questions.
I'm still lost, but I don't want to hog this, so I'm gonna.
Well, and maybe what we can do is, and I'm happy to have even a longer conversation offline. I think maybe as a summary here is the observed to expected is just one of a variety of ways that we thought and justified why chest pain and dyspnea were appropriate besides their clinical relevance for patients with suspected heart attack symptoms as a quote miss in the 30 days prior to an AMI event. But it does get tricky because the different patient populations and the different calculations of the actual observed and the actual expected. But maybe we can move the further details offline just to.
Sounds good. Sounds good. Thank you very much.
Yeah, good question.
So a question from Chuck, who asks, what plays the biggest role in the misses, and what can you learn about how to not miss a diagnosis?
Yeah, really important questions and key questions. And I will say that this approach doesn't answer that. I think this approach is a standard way that we might define a miss that would be generalizable to either other health systems. So this study in and of itself, I mean, does not tell us why these were missed, but I think what it does is it potentially identifies an opportunity for us. I love the quotes around, if we can't measure it, we can't improve. And so I think this is the first step. And if we could agree upon a way to measure something similarly, then we can work towards answering these questions around, what plays the role and how do we actually avoid making these misses? Are these patients that never got an EKG, or are these patients who never got a, troponin, which is the most common lab test to identify, ACS? So for purposes of this study, we didn't look at that detail, but is certainly a really important question and next steps on this type of work.
And another question is, did you review any medical records to validate that the coded diagnoses were accurate?
Yes. So the short answer, and one of the challenging things of this, and again, is part of our approach. So so for our patient population, we used both patients who showed up to our hospitals, of which we have all the information, as well as claims data for patients who showed up to hospitals outside of our system. And we had a lot of conversations amongst our research group around what was the best approach. Obviously, we have much more detailed information if we look at just our system. But the problem with that is few systems are similar to ours. So the short answer to your question is we did look internally to validate the codes, and there's pretty robust evidence to show that amongst administrative data, generally speaking, that a primary diagnosis of AMI is very accurate on a hospitalization. So we looked at it internally, and it was accurate. In previous research, they've shown that in claims data or administrative data that AMI as a primary hospitalization diagnosis is accurate. So that was kind of the basis for our primary outcome here. Yeah, so it looks like another question about this study allows any hospital to calculate its O to E ratio with the study population. And that is correct. You could certainly calculate your observed to expected ratio, which may create some challenges with the expected. Again, I'm not sure that the observed to, I mean, if it were me, and I'd love for others' thoughts, I don't know that this is right. I'm not sure that the observed to expected ratio would be the number that I think would be most useful for comparison. It might be the quote miss rate, meaning how many patients with chest pain and dyspnea did we send home that came back with a heart attack within 30 days, which is a little bit easier calculation.
So question from John is, if you can't measure it, you can't manage it actually, sorry, excuse me. If you can't measure it, you can't manage it actually misquoted and.
Yeah, I wasn't actually referring to Deming, though it's often attributed to him. John, if you want to unmute, I can't read the article, but I'd love to hear your comments.
Oh, yeah, sure, no problem. It's just that that's often taken out of context, and he actually said the opposite, that we kind of are moored too much to measurement, where that inhibits improvement. So if you're a Deming aficionado, he actually doesn't kind of buy into that precept. Although, yeah, I think others may have said that.
Yeah, what do you think?
I don't know. It depends. I don't know that I've seen where administrative data has really helped, my clinical practice too much.
But where do you practice and what do you do?
I'm just a general internist, outpatient, community medicine, and a lot of these studies come out, and sometimes it's with big data sets, and I think it's hard to always know what we can learn from them.
Yeah, I think it's so you bring up a really important point, and I appreciate you bringing this up, because this approach is frankly not terribly helpful to practicing physicians at the time of the encounter. Physicians have been trained to know that chest pain and shortness of breath is a possible risk factor or symptoms concerning for a heart attack. So I think you bring up a really good point that this is more at a system level. So, like you said, I think there's ways to improve the system. And let me give you an example. So part of the reason I was interested in this particular research is we have implemented across our 15 emergency departments and hospitals. We use HEART, but a risk stratification tool to identify which patients we're recommending should come into the hospital for potential stress testing versus go home. And the downside, and with the main emphasis that we were admitting way more patients and causing potential harm with the adverse events that some of these things could do without actually helping them. So that work was much more at the patient level and looking at how things went. And this work is really intended to be able to say, how well does my hospital do, or does our health system do? It's a much more population level. I think there's no question that there's drastic limitations for administrative data and these types of population level approaches. I'm a huge advocate that we've shown in our system that when we can show physicians their performance and can show them what we think is the right thing in terms of clinical reference, we have been able to improve care, at least based on how we define quality, affordability, and all the kind of domains that timely, efficient, safe, patient-centered, all those things that we think are quality. So I think it has merit, but you're totally right. At the individual patient level, that's not where this is really terribly useful.
Great, thank you.
So Chuck asks if you could show the equation that calculates the miss ratio again.
Got to find that slide here since I just cut and paste that into no man's land. Here we go. So this is so I will just, with the one caveat, that to remember the observed encounters and total of 30-day ED visits is different depending on the look back versus the look forward. But we used a similar expected ratio for both.
Adam, I'm not sure if you have the actual numbers available to you. Chuck asks if we could fill in the numbers with the KP study.
I don't have them in front of me. I mean, we certainly have them. It's how we calculated the numbers on this slide, but I don't have them in front of me.
Chuck, they are included in the article which we attached if you want that as a reference. Any other comments or questions?
I'll say one thing that is a project that we're currently using this approach to try and help is, as a practicing emergency physician, one of the groups that I was worried about that I think many have talked about, but I hadn't seen much data around, was, specific subgroups. So we know that, for example, women can be missed more than men for a variety of reasons, whether that's implicit bias or whether that's because they present with different symptoms, all potential reasons. But another group that there was thought there's some preliminary data to suggest with patients with substance abuse problems. So patients that use IV drugs or have other substance abuse problems might be a group that might be missed at a higher rate than the general population, as well as patients with mental illness. So obviously anxiety is often something that emergency physicians might think of or attribute symptoms to, as opposed to acute coronary syndrome. So just as an example, that's, I think, a place where we thought that we might be able to identify a group that had a much higher miss rate in the look forward cohort, which is the cohort that might be able to be approached from kind of a system level quality improvement perspective. So to be determined, but I think that's potential next steps is identifying a group that we might be able to target. And I think a little bit to John's question that or comment that, that might be an opportunity for physicians to actually be informed about, hey, here's a group that actually you should think twice about if they come in with chest pain or dyspnea. If they're a female substance abuser with a history of depression or anxiety, that for example could be a group that's much higher risk and might be able to change our practice and eliminate some of these misses.
Okay, great. So if we have no more comments, we can go ahead and close out our session. I'd like to thank Dr. Sharp and everyone who joined us today. As always, we welcome any recommendations for the upcoming journal club sessions, and we're happy to hear from you. Thanks everyone for coming. Take care.
Thanks everybody. Bye-bye.